inflammation and oxidative stress, they're really elevated. You are also what we call compound heterozygous for both MTHFR-C677T and A1298C. And while that is in and of itself useful, what's more important is that your homocysteine is elevated. Here's MTHFR, right? And here's your homocysteine. And really when we're thinking about single nucleotide polymorphisms having to do with methylation, they're really just susceptibilities. But then we find things that tell us it's a little bit more than just a susceptibility, it's actually clinically relevant. And in this case, your homocysteine elevation tells us it's probably going to be something that really matters. So the next time we meet, we're going to go over your genetics more fully, not just MTHFR. If you go to page 6, you'll see, you have something like 25 parameters of blood sugar stability, starting with glycemic control, and then you got insulin resistance and beta cell function. And you can see that there's a lot of concern here. Now, since we are interested in what your adrenal system is doing and your HPA axis, or more specifically your HPA-GT axis, hypothalamus, pituitary, adrenal, gonadal, thyroid axis, I know that bears heavily on sugar stability. The extent to which your neurochemistry is collapsed really matters on how you feel on a day-to-day basis. There's another way I like to describe this to people. So let's paint a picture of what might be going on. So HPA axis stress creates an increased demand for cortisol. Cortisol skyrockets. It totally upregulates your stimulatory neurotransmitters. That excites the nervous system. You need to counterbalance that by spending a lot of your calming neurotransmitter, which sedates the nervous system. And you basically are just cashing in. And then there is sort of a plummeting impact. The first stage of plummeting is dependent on who you are as an individual, genetic susceptibilities. If you have a lot of these interpathway particular susceptibilities, which again we're going to talk about next visit, and those are clinically relevant in your case, it helps us understand which neurotransmitter is going to be impacted to the greatest degree first. You need tests that help you verify what your status is for cofactors. For instance, the synthesis of serotonin requires B1, B2, B6. It requires phos. But sometimes the HPA axis collapses first. Sometimes it collapses first and then hormones and neurotransmitters follow right behind. The bottom line is we paint a picture right here. Your HPA axis, if you look at your cortisol, it's really low. And even where they say it's normal, it's just outside of the threshold for normal. Every patient has 2 or 3 lab review visits. And at the end of every lab review visit, what I do is I'm going to go ahead and dictate the summary of these. It's very helpful for you to sit here while I'm doing that because you get to hear it again, but you also get a written copy. Basically, this is just my impressions so far with the first 2 tests. Now what we're going to do is we're going to look at the biological markers and we're going to cross-reference them to single nucleotide polymorphisms and hopefully provide a deeper level of explanation as to some of the things that might be contributing in terms of susceptibility with regard to neurotransmitter pathway methylation, SAM-dependent methylation as it pertains to neurotransmitters, and any number of other things that will help us. Let's go ahead and take a look at the FMV, and you'll follow along right along with me. So your pooled antioxidants, for the most part, are holding up well. Now if you go to page 10, you'll see that your oxidative stress markers are also relatively non-contributory. So what that means is there's no indication that your body is struggling from cellular oxidative stress. And just so you know, what we're measuring there is the tendency for peroxide accumulation in the cell to over time damage DNA, lipids, and proteins. So 2 of the markers that we're looking at, one is peroxidized lipids and the other is essentially peroxidized DNA. If you look at your B vitamin status now, there's a different story here. You can see you have some pretty significant B vitamin deficiencies. What this isn't telling me is methylated versus unmethylated. This is actually pooled values. So you could be overwhelmed in terms of unmethylated folates, but depleted in the methylated versions. Same with B12. Your physiology could be overwhelmed with B12, but relatively lacking in the methylated B12. And of utmost importance in this kind of a picture is determining whether or not you fall into the over-methylation or the under-methylation category. Because homocysteine can be abnormal in either, and there's a subtlety in it that's really important to identify. So the bottom line is as soon as I see this pattern, it requires another level of testing, which is confirmation of whether or not you're over versus under methylation. And one of the easiest tests to do that with is a whole blood histamine. Now there's another test that we could do, which is the SAM-cell ratio. However, that test is a lot more costly, and I reserve that test for a as needed only basis. So in terms of malabsorption, there is some indication of at least moderate level malabsorption. And in a few minutes, we're going to cross-reference that to your 3-day stool sample and try to understand that at a deeper level. But for now, we're just going to accept that the elevation of PAA indicates a moderate level of malabsorption. Now, with regard to mitochondrial metabolites and cellular energy, you have some elevations here. The pyruvic acid is in a moderate level elevation. Where we are impressed is when we take a look at page 8 and we look at your neurotransmitter metabolites. And do you see how the HVA, or the homovinylic acid, is significantly elevated? So HVA, in short, is a dopamine breakdown product. And it's the result of activity by COMT and monoamine oxidase B. Now, this here and an HVA elevation, we assume a number of possibilities. First of all, an accumulation of dopamine due to a relative stymie, if you will, of DBH, which is one of the main drivers turning dopamine into norepinephrine, norepinephrine into epinephrine. But also, one of the chemical drivers to turn norepinephrine, epinephrine in from dopamine is PNMT, which is driven by cortisol, and we know that you're woefully depleted in cortisol. So this actually makes sense, but at the same time, it also tells us that your nervous system is struggling from a dopamine perspective. Now the 5-HIAA right here, which is actually a metabolic byproduct of serotonin through the enzymatic action of monoamine oxidase A, is also slightly elevated. The overall interpretation when you look at this is that your physiology is very ramped up, and you're spending. Now, if you have trouble making, because of all of this, because of a relative lack of SAM-dependent methylation, because of interpathway susceptibilities having to do with single nucleotide polymorphisms and whatnot, then I think one can assume you're going to be struggling more than the average person. Now, take a look at your amino acid profile. And just like suspected, your cysteine level is quite elevated. See that? 125. Now, I've seen it a lot higher, but the cysteine elevation, there's a clue in it. And the degree to which the cysteine is elevated helps me understand the degree to which this transsulfuration pathway is stressed. But your homocysteine elevation isn't leading to a methionine elevation, at least not to the same degree it's leading to a cysteine elevation. So my guess is you have genetics that dictate that it'll go this way instead of that way. So the idea is that the physiology is dictating the shunt. But the pressure that puts on metallothionines and the glutathione-specific pathways. The other thing we see is an elevation of glutamic acid. You can see it's in the red there. And so that is the same as saying elevations of glutamate. So again, I'm interested in your GAD susceptibility, which is the ability to turn glutamate into GABA. So we'll be looking at that soon. Okay, so let's take a look at your GI effects and see if we can make sense of the organic acid abnormalities we saw in the FMB. So the first thing is when you look at page 2, which you'll see that you have ample production of pancreatic elastase, which really represents pancreatic enzymes as a whole. And then when we look at the breakdown products of protein, those look okay. But then you go down and you look at the fecal fats, and you see, okay, those are trending towards elevated, and in fact cholesterol is hyper-elevated. This is somewhat of a very specific presentation of malabsorption. So we're going to look at IgA susceptibilities, and remember IgA is the primary immune protectant, if you will, a surface protectant for endothelial cells that line hollow spaces. So this would include your bladder, your sinuses, your inner ear, your digestive system, of course. Then I look at the microbiome and I don't see any major overgrowth, although Bacteroides are significantly higher than they should be in Clostridium is in some level of imbalance, but it's not considered a overly significant bacterial overgrowth, but it is a dysbiosis, and the way we know it's a dysbiosis and an unhealthy one at that is the F to B ratio. In functional medicine, we're becoming more and more interested in the F to B ratio, and we don't like to see it so low. So whereas you may not require an extensive GI remodel per se, we certainly have to pay some attention to the digestive system in terms of getting it balanced. All right, we're on the last leg of what we're planning to do today. And so this is where we get into the single nucleotide polymorphisms. And let me just start by saying the details of this 42 pages of what we call SNPs can be very overwhelming. We'll hone in with a microscope on SNPs that really matter. What determines if they really matter is what I already know. They're biologics, so your elevated cysteine, your elevated homocysteine, your elevated glutamate, your elevated HVA, and HIAA. We're going to look at everything as a whole so you can kind of understand your genetic susceptibilities at baseline. It's very valuable to know the cards you hold around the game table of life because you can play a better game. So when we look at the SNP report here, you can see the first column is RS numbers, and the RS number represents the highest level of detail on exactly what type of SNP we're dealing with. The next column represents the SNP name, and in this case you can see that there is an entire page, in fact 2, on CYP, which is cytochrome P450. And then the subtypes, you can see how line item 1 is CYP1A1 asterisk 2C, and line item 2 is CYP1A1 asterisk 4. Honestly, it's the pooled susceptibility when we're looking at something like cytochrome P450 that we're concerned about. And then the next column is the abnormal allele. The next column is your result. And the furthest column is whether you inherited that once, twice, or not at all. A negative negative means wild type. That's the ideal. A positive negative is heterozygous, and that means that you inherited one copy from mom or dad. 2 positives, or positive positive, equals homozygous, and that means you inherited an abnormal single nucleotide polymorphism from mom and dad. So in 42 pages of SNPs, you're going to have hundreds and hundreds of SNPs, and I'm not going to discuss all of them, because some of them, quite frankly, they just don't matter to me. So what I would do is I would pay very close attention to the ones that I'm telling you are important for your particular clinical situation. And to the extent that it appeals to you, learn more about those. I'd like to think that I'm going to teach you just about everything you need to know about the SNPs as they relate to your biologics, as they relate to your presentation. And hopefully that will be enough to satisfy your curiosity. There are 2 slots per line item, and we know there's 50 slots per page. So out of 100 gene slots, you're positive for 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11%. That's minimal at best in terms of susceptibility. It really is irrelevant. So in terms of your phase 1 detoxification, you look fantastic. Why does that make sense? Well, I have a test that shows you don't accumulate organic toxins in the liver, such as MTBE, gasoline additives, styrene, some other things that we checked for. So now I have a genetic test that sort of tells us about the biologics. Now phase 2 detoxification has some interesting points here. A couple I'll bring out. Some of them are going to be a little redundant. That is to say that some of the SNPs in the phase 2 detoxification pathways also exist within the methylation categories. I just assume talk about them more in the context of methylation. Suffice to say, BHMT, CBS, these all have to do with detoxification, but they also have to do with methylation. Now the glutathione-specific pathways, here we call GGA, GGT, GSR, GSS, these all look decent. You have some mild susceptibility, but because you don't have any biological evidence of a lack of glutathione, we're not concerned about it. You have a few hemochromatosis SNPs, but because you have lab work that doesn't show any elevations of iron, we're not concerned. You definitely have some susceptibility with regard to BHMT and MAP, but again, we'll talk about that within the confines of methylation. NAT chemical clearance, mild susceptibility at best. So you know, from my perspective, when I just look at the big picture here, your both your phase 1, your phase 2 detoxification, your liver-related SNPs, your chemical clearance SNPs, and at least your core transsulfuration pathway SNPs are all looking pretty decent. So here's how the discussion goes from here. What I'm focusing on right now is this right here, what we call early methylation, early transsulfuration pathway stuff. Now, why is it so important? It's because the early methylation pathways really are sort of that pivot point for how stable SAM-dependent methylation is. And SAM-dependent methylation is so important for so many things, not the least of which are the neurotransmitters that we're interested in this case, see SAM-dependent methylation. In all reality, SAM-dependent methylation, the vast majority of it goes towards the creatine cycle. But it's not without clinical importance that SAM-dependent methylation is the driving factor for neurotransmitter interpathway metabolism. Okay? All right. So, what I was telling you is we know you're compound heterozygous MTHFR. We also know that you have a deficit of pooled folic acid. We now know that you are more susceptible in terms of MTR than you are MTRR. And when you combine the MTR susceptibility with the significant BHMT susceptibility that we've identified, along with the MAT susceptibility, it helps us understand why homocysteine accumulates. It also helps us understand why there's a relative lower value of methionine, and we would surmise that that impacts SAM-dependent methylation. It's really the SAM-SAW ratio that determines SAM-dependent methylation pathways, but that SAM-SAW ratio is so easily altered by these kind of abnormalities. So, DMG dehydrogenase in your case is also in trouble. Now, the CBS pathway though, the SNPs that you are positive for are what we call obstructing, not upregulating. So that's why your ammonia levels are lower in your urine rather than higher. See, usually with the CBS upregulation, you're going to get higher ammonia levels. But then you also would have a low homocysteine. I would say that from a methylation transsulfuration pathway, you are definitely more susceptible for methylation. Sulfation doesn't look that bad. You definitely have what we call an electron donor block due to an altered SAM-SAW ratio. And the SAM-dependent reactions are not well supported. And so there's this metabolism block, leads to an energy block, neurochemical block, hormone immune block. And so here we find that the early susceptibilities within this pathway are providing a decent next level explanation, if you will, of why neurotransmitters and HPA axis are seemingly out of sorts. Does that make sense? When it comes to these SNPs, I know your most important is MTHFR and MTRR. MTR to less extent. So I'm going to encourage methylated folic acid over methylated B12. But what do I have to do first? I have to make sure that I'm confident that you are not in an over-methylated state. Because there are the possibility of shutting down this system is equal to undermethylation and overmethylation. And the SNPs that you have, that we've identified here in your case, are equally able to create over versus undermethylation. Herein lies my consistent observation that one cannot make a determination about where a person is in terms of over versus undermethylation based on SNP susceptibility alone. You need medical testing. But I really believe that people are out there harming themselves, being in an overmethylated state, unknowingly treating themselves with methyl donors. Okay. The first line item here in your case is a standout susceptibility that is not very common. Now I see a lot of heterozygous, that's plus minus. But when I see a plus plus A NAT, which is this important metabolic step of turning serotonin into N-acetylserotonin and then onto melatonin, I automatically assume one who has this is highly likely to not be efficiently turning serotonin into melatonin. Now again, a susceptibility is only a susceptibility. But so then the next thing becomes is, do you have symptoms of a lack of restorative sleep? Next section talks about CompT, and even though you see a number of positives there, I will tell you that in the grand scheme of things, that CompT is not that relevant to me because I've seen people with reds all the way down. So you have some heterozygous CompTs, some of the important ones are affected, but I would say that your CompT susceptibility, which is catecholamine-O-methyltransferase, breakdown of norepinephrine, epinephrine, and dopamine, is standard. When I benchmark you to other people, I don't see any standout susceptibility, if you will. Okay, so I would call this mild susceptibility. Remember I told you I'd be interested in looking at DBH, and that also doesn't look too bad. You have a few homozygous, but for the most part a lot of green. So that doesn't provide us the explanation for the high amount of HVA that we're seeing. So the only other explanation is that you're utilizing, producing, spending, and breaking down high amounts of catecholamines, i.e. dopamine, adrenaline, noradrenaline. We have an impressive display of susceptibility on page 19. Out of 12 or so GADs, you are heterozygous for all except 2. So what does that tell me? That tells me your genetic susceptibilities are most impressive as it pertains to GABA, not dopamine and serotonin. That doesn't mean that you're not depleted, because remember, when you spend and spend and spend, you do deplete. But where we're, at least from a genetic perspective, behind the curve is with GABA. That's a real blessing to know, because you see we can capitalize on your neurochemical strengths and pay extra attention to your neurochemical weaknesses. You have to build the foundation in terms of the cofactors that we see are in trouble. We have to support the methylation pathways in a proper way. Then we'll have unimpeded neurotransmitter rehabilitation take place over time. It's meant to be reparative. Now, it isn't always reparative. Some people have brokenness, but we assume going in with every single patient that it's not brokenness, it's depletion. And that assumption proves true more often than not. Now, when I'm working with kids on the autism spectrum, or adults with head injuries quite significant and other things like that, then sometimes I have to say, well, we're going to do the very best we can, and what we're left with, we're left with. It's this phenomenon where, how far from the ledge were you at birth? In terms of your genetic susceptibilities, and what are all the different, sort of insulting events that knocked you closer and closer and closer and closer to where you drop off. Why is it different now? Because it's this knock, 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 and then when you fall off the cliff, the rules change. The rules change in that now you're in the dumps, and constitutionally, your physiology just isn't able to handle what it used to handle. But see, the difference between being in the dumps and on the ledge, there's a pretty significant distance to climb there. But once you're back on the ledge, whether you're on the tip of the ledge or whether you're this far away from the ledge, it all feels the same. It's just there's this dropping off point where now something suddenly has changed and your physiology is not keeping up with demands. Now that said, oftentimes the trick is, because of our age and stage in life or whatever, we're kind of walking on the razor's edge on this side and that side. And so the idea is to stay on the razor's edge to the positive, so that we live a higher quality life. But when you flip into the negative and you feel yourself slipping, you have to take concerted action at that point to take care of yourself. Now remember, working with me at this level really ends with the lab reviews. So this is your time to truly understand what's going on. The need for this level of interaction is just, it doesn't exist beyond the first 2 or 3 visits. But the fact that we put so much time and energy into getting this sorted and so well thought out in the first few visits really is a huge time and energy saver down the road, because we're so crystal clear on what needs to be accomplished. There's a lot of value I have found over the years in just really giving these first few visits what they are due fully, in terms of making sure that you fully understand what's going on, I fully understand what's going on, and we understand the project as a whole. Because you see, there's a number of things to accomplish over the next, say, year and a half, and they have to be done in a particular order. And so when we can get to the molecular biological level and assess it from that level, we really are at an advantage. So the fact that we can use single nucleotide polymorphisms and cross-referencing of biologics to explain this at this level is truly a blessing.